Good afternoon and welcome to UnitedTV and Bariatric Friday. My name is Kemal Erkan. Today is Halloween, October 31st, 2025. We are going to focus on one of the essential but very often overlooked element of bariatric care with the care coordination aspect. From initial evaluation to post-operative follow-up, the success of bariatric surgery relies on well-orchestrated team effort. And this team includes the surgeon, of course, and dietitians, primary care, endocrinology, behavioral health specialists, and nutritionists as well. So please join me with our discussion with Dr. Erkan, and we'll be able to tell you more about the care coordination aspect of bariatric surgery. Dr. Erkan, how are you doing?
I am doing great, Kamal. It's wonderful to be back on my favorite session, Bariatric Friday.
It is my favorite session as well, and I forgot to apologize. We started a little bit late. There was some discussions that we had with Senator Nicole Poor after her session. So then, it wasn't anything other than that. So, and she did a really great episode with us. I hope everyone enjoyed that as well. So, the bariatric surgery is not a standalone intervention, so it requires pre-surgical assessments, nutrition counseling, and other clearances that it may not be very common for other surgeries. So, with the coordination, critical steps, without the coordination, critical steps may be missed. And from the clinical side, from the surgical side, why is care coordination critical in the bariatric surgery process?
Well, it is critical for the reason that you mentioned yourself, Kamal, and that is bariatric surgery is not a standalone procedure. It's really a process that has a number of components to it. There is the medical component, there is the nutritional component, as well as the behavioral component. Care coordination really ensures that these three facets interact and flow through the process of evaluation, the actual surgery, and the follow up in a seamless fashion. That really will ensure that there is less miscommunication. It will ensure that we will adhere to the guidelines that we have in a seamless fashion, and also it will have an impact in the outcome as well. So trying to do bariatric surgery just by itself, we've seen it in the early days of bariatric surgery. It was not a good idea. Bariatric surgery has become really accepted, established, because it also brought these important facets with it, right? That it requires nutritional support, it requires the behavioral component, and then the medical side as well. And that cannot be really brought through in a successful way unless you have a very well orchestrated coordination, which the coordination team gives us.
Absolutely. So, many patients who present in our offices with morbid obesity, they also have comorbidities. These are related illnesses like diabetes, hypertension, and sleep apnea. And managing these before and after surgery requires collaboration between specialties. And I think, in a way, from the organization standpoint, we are lucky because we are part of United Medical ACO, and United Medical ACO is a multi-specialty ACO, and we have full clinical integration of our PCPs and specialties. They are in one chart, one patient, one chart model that's powered by Oracle Health, and that's not really common in the outpatient settings. And maybe this is from the communication between specialties. It makes it easier as long as they're in network with us. But still, this requires a lot of work. How does care coordination help manage comorbid conditions in bariatric patients?
So, as you mentioned, that coordination between the different specialists or consultants that are taking care of different aspects of the illnesses of the patient, whether it's diabetes, whether it's sleep apnea, whether it's hypertension, that coordination requires a structure. It's not just the doctors knowing each other, knowing their cell phone numbers and calling each other. It requires more than that. It requires a structural integration, right? So, for instance, how often an issue came up in your case conference where you were able to look at the schedule of the endocrinologist because it's part of your network,
Right.
and you were able to see that they may be available on a Saturday, and a patient that could not have any other appointment on any other day, you are able to fit them into that slot without talking to the endocrinologist.
Right.
So it's not about the doctors knowing each other. It's the system having some integration that is really orchestrated by the case coordinators, so care coordinators. So that's really what is very important. Now, that will bring about qualitative outcomes to us, right? Because if I am able to take care of the hemoglobin A1C, which is an indicator of how serious the diabetes is, the blood sugar issue is, to a good level before the surgery. If I am able to manage the medications that the patient will need after the surgery in reducing the diabetes medications in a successful way, then I am reducing the potential complications as well. So care coordination does bring about, tangible outcomes in terms of reducing complications of our patients by coordinating the care that is provided by the different specialists.
So we have care coordination for our patients, and we have my older sister for our family coordination. So she was just sending me a warning saying that I'm not focused on today's session. I'm like, well, it's because we have a little bit different setup. I don't know if that's how it looks. I thought I was looking at less places now. So, but hopefully it's not too bad. I don't know.
I watched the session. I didn't think there was any issues at all.
She's like, go back to your work. So, okay, sister. So I want to add something to what you just said, Dr. Erkan. And in fact, it just happened yesterday. And with the endo, one of our patients with really high A1C started the program. I think the A1C was 12.1, 12.2. With Dr. Handal's office, it's now down to less than 6 in 2 months.
Wow.
So this happened, of course, we did the fructosamine test, and the fructosamine was, I believe, 240.
Okay.
If I'm not mistaken. So it's either 240, 245. So, but then we still needed to have the clearance from the endocrinologist, and then endo is asking for the blood work. The reading of
the daily blood glucose log.
And we knew what it was because we were on the same chart. And then patient didn't have a really good understanding of that. And then we are like, hey, so here's what it is. We can see his note directly, and then this is what you have to do. And now that patient is going to be at surgery, I believe Tuesday or Wednesday this coming week. And because those things are so important, because if the blood readings are not there, then we may not be ready for the surgery on Wednesday. So every little bit is going to impact what's going to happen. So it was one of those when you were talking about the endocrinologist, because we sent the message to the endo, and then they're like, we are working on it. Patient did submit everything, I believe, already. So it's all in good shape. And it is, if you think about it, the system that we have, the quick-based system that we pretty much designed from scratch. Actually, and how much we have to spend time and effort to make sure that patient is ready to go. Minimum 25 if they don't have any abnormalities. 25 individual effort that we have to make. And if they have issues, it can go up to like 50, 55 different activities throughout the 2 to 3 months. And it's not just doing the coordination, but it's being able to record that and make sure that these are readily available for everyone. That's another thing. And so I'm actually extremely proud of what we have already.
Oh, absolutely.
In place.
You should be, Kemal.
So preoperative readiness includes medical, nutrition, and psychological assessment. Delays or gaps in coordination can slow down the surgery approval and increase patient frustration.
Mhm.
So, what are the common coordination challenges before surgery?
So, problems as little as, missing the paperwork. Uh, the clearances have been delayed, or if the clearances have been done, the information about the clearances is not here yet. Lack of communication from that point of view, as well as the ineffective communication between the referring physician, the consultants, and the bariatric team, right? These are real problems that can happen in any process where there are different players, right, taking care of the same problem. That's where the care coordination, right? That team that meets day in and day out every weekday, right, is looking at all this and fixing them, right? So if there have been a problem because paperwork was missed or because the clearance did not come, if the care coordinator or the bariatric team is meeting once a month, Kemal, how many issues are they going to be able to fix on time, do you think? Not very many, which means that the patient's care will be delayed, right? One of the interesting things that, I used to hear from patients in the past was, I would tell them about the surgery. We would talk about indications, the potential complications, and also how to prepare for the surgery. And I would say to them, well, you have to see a nutritionist, you have to see a psychologist, we have to do endoscopy, we have to do blood work, we have to potentially get you to see a cardiologist, maybe you have to do a sleep study. And some patients would say, are you making us do this, or are you making my loved one do this, all to test them to see how far they can resist and how determined they are? Because it looks like that, but it's not like that. In fact, the bariatric coordination is trying to make these things as easy as possible. We're trying to, right? But these steps are important. The nutritional preparation, the psychological evaluation, endoscopy, the cardiologist's assessment of the patient to make sure that they are fit for anesthesia. These are critical components that will work towards the success of the patient so that they can go through the surgery safely. That's why our complication rate is so low. And then they will be successful in the long term. But we don't have to make these steps difficult. It's not easy to get patients to go to different places in a coordinated fashion. But if you have a good care coordination team, you can make it work. And your team has demonstrated it. Oh.
Thank you. And again, these things are not rehearsed, so we didn't talk about how we were going to say certain things, and just some of them because this is what we do every day.
Yeah, absolutely.
One of the things that I remember is the patient that you operated this week. I think it was your patient. Had another high A1C patient.
Oh, yes. I know exactly who you're thinking. Yeah, this week, you're right.
I was like, it was a project for me. Like,
Yes.
I'm like, okay, so we are going to go through this. We are going to go through this. And if you look at
And
his,
she was very, very
this
thankful.
is the guy.
Oh.
That's the other one. This
Okay,
is the guy.
okay.
And then I know who you are talking about
Yeah.
too, but the CD is the initials.
Okay.
So I just took it so like personally. I'm like, normally I don't call the patients, so I'm kind of leading the chairing the case conference. But I knew that this patient needed more support, and when you call them, like it's not just I don't know what you think about this, Dr. Gao, but it's not just about getting the specialty appointments or follow up, but also they need to be heard. And I'm talking to this guy, and then he is struggling, and he didn't think he was going to go through. And I'm like, nope, we are going to go through. We are going to be fine. And I know what needs to be done. And each time I talk to maybe 3-4 times, which is, as you know, it's not common.
Yep.
I mean, for me personally, it's not common, but I'm there to manage the rest of them. And then he did it like this.
Yeah.
So, and that other person that you mentioned is another one that we have close to 65 different activities
Make that happen.
to make that happen. Now, of course, not all of them are the same. So a lot of, maybe 80% of the patients are going through a very smooth ride, but there's that 20% that needs more help. And then we have to be there for them.
Yeah.
Now, post-surgery follow-up is a high risk phase for complications, non-adherence, and or weight regain. So active coordination ensures timely check-ins and interventions, and this is one of the areas where care coordination, I believe, is important. How does care coordination impact post-operative success?
Well, they do because they follow up, right? The care coordinators follow up with the patients by reminding them, by tracking their lab work, by seeing how often they are seeing the nutritionist, by seeing whether they are keeping their appointments, right? So all that helps us. In the real world, when we tell patients we want to see them at 2 weeks, at 1 month, at 3 months, 6 months, and then in between then they will be seeing the nutritionist as well. And they may have a follow-up with their cardiologist as well because adjustments may be needed to their blood pressure medication. The same with the endocrinologist. That is a lot of appointments that it is easily understandable for patients really not to become not to be up to date with all this because they have a life to run as well, right? They may have they have a family, they have a job, they have kids, they have other things to do as well. Having the care coordinating team contacting them to remind them, right? Hey, you have an appointment coming up with your bariatric surgeon. Before that, you will need to do your blood tests, or your medication has not been adjusted for a while. You may need to see your cardiologist. All that coordination is done again so that the outcome that we have from surgery is sustained in the long term as well.
And again, with those different management that patient has, it's now because we do this for so many years. As soon as I see the case, I know what needs to be done. Like there's one patient last week, the PCP was managing, this is out of network, managing the diabetes, but we don't have the right mix of medications. So then from the ACO side, I call our pharmacist and then ask her opinion, and she's like, okay, so this is not enough. So then this patient needs to go to the endocrinologist. So because we know right away what's wrong anymore. So the other thing that we also know is in some cases, and just earlier when we had the session with Senator Nicole Poor, the social workers that we have in the ACO, they are also extremely helpful. Now, not every patient needs the social worker intervention, but when we know we have a lot of Medicaid population, a lot of patients, and again, Nicole was also talking about the same thing where patient doesn't know what's available to them. So the transportation cannot be a problem if you have Medicaid because there's transportation available.
Yes.
You just need to know this is available to you, and then you need to know how to access to that. So sometimes if the patient doesn't want to do that additional work, then we have our social workers holding their hands and make sure that they get what they need. And of course, technology itself is a huge impact overall, how this coordination can be complete. And one of the reason, is as a patient, we want to be able to access to our own data and then understand what's in the chart. So, and then this is where the technology can come in very handy. Now, Dr. Gav, we mentioned the ACO and value-based models. And then these models emphasizes measurable outcomes, making coordinated care and operational necessary. And how does bariatric care coordination fit into the value-based models?
Well, it fits perfectly, really, because if you think about it, the principles that guide the value-based models are reducing admissions, right? Cutting costs, and make sure that there are good outcomes, right? These are the three tenets. And care coordinator really works on that, right? If care coordination is in place to follow up a post-operative patient, for instance, if that patient is followed up and reminded to go and see their endocrinologist to make sure that their blood sugar is doing well, then they are less likely to end up in the emergency room with a very high blood sugar level.
Right.
Right? So that is why I'm thinking that, in fact, care coordination is really the structure that would allow any value-based organization to flourish, really. Because without care coordination, without having that mindset of care coordination, you cannot coordinate the care of the patients, which is all we're talking about, right? The days in which you had one provider, one physician taking care of patients, right? Those days are gone, Kamal. We cannot take care of a large population that requires
Absolutely.
complex care just in that fashion that we had in the past. We have to have a coordinated approach to this care, right?
Right.
So that every patient will have a number of people watching over to make sure that their care is rendered appropriately, navigating the complexity of the healthcare system. So care coordination really fits very, very well with the models that we have with the value-based principles.
So with that, primary care providers, they are the core element of the care,
Yeah.
and they are the center of the care. And also for any long-term follow-up, they are still essential, especially once patients transition out of the surgical platform program.
Yeah.
What is the role of primary care providers in the coordinated care model for bariatric patients?
Well, as you say, they're key. They're the foundation, right? They are the ones who have the long-standing relationship with the patient, obviously preceding bariatric surgery, but also after bariatric surgery. So a relationship with the PCPs that is based on good communication between the bariatric and the PCP is essential, right? So that the care of the patient continues in the long term in a successful manner. The other side of this also, Kemal, is that the primary care is the one that first identifies problems from a medical point of view, right? When a patient walks into their primary care doctor with a body mass index of 50, right? And they don't know that they have a very high hemoglobin A1C, their blood pressure is running amok, and they have sleep apnea, it is the primary care doctor who will say, well, that patient needs the most effective treatment for all these problems, which is bariatric surgery. And they are the ones who will refer that patient for bariatric surgery after having done the appropriate assessment, right? Once they've done that and bariatric surgery with all its complex care is completed, that patient returns to the care of the primary care doctor who will now have the same patient with a different health profile now, right? Improving health profile. For that to be a sustained success, because as we know, obesity is a chronic disease. We cannot let patients just go without any follow-up after we do bariatric surgery because they will struggle again. So the comorbidities can return, the weight gain can happen again, other problems can be faced. So that coordination with the PCP is actually essential. So one of the, even in my long-term follow-up patients, when I see them in the office, is 1 year, one of the questions I ask them, how often are you seeing your primary care doctor? And the answer I want to hear is at least once a year from that point of view as well. So really the care of the primary care doctor is really foundational when it comes to any type of care, Kamal. Obviously, this is very important for bariatric surgery because obesity really touches so many aspects of the health of the patients.
And again, like one of the recent news that I had from the medical side, there's a sleep apnea treatment, some device or something, so something new. So we are talking, and I'm like, well, what's the patient's BMI? So if I don't have that information, why do I want to put the patient through that? Because the root cause is
Obesity.
patient has morbid obesity or obesity with the sleep apnea that comes from it. Of course, if someone is with the low BMI and if they still have sleep apnea, that's going to happen. But before I do anything, I need to address the obesity part of it. So, and then this is where primary care also is very helpful because they can see those things and make sure that patients are getting the right treatment. And again, we are going to look at it from the surgical side, but then they will see everything overall to make sure that patient doesn't go through any other problems. Now, my final question for today is patient engagement is it's a final and most crucial link in the coordinated care.
Yep.
Education makes patients to make better decisions. So how does patient education tie into the care coordination?
Well, patient education really is very important because it does empower patients, first of all, to understand their journey, right? And they will be able then also to be, once they understand, they will be able to be much more compliant with the education that they've been given from the nutritionist, with how to approach and how to manage many behavioral problems that can occur or mental health issues that can occur either pre or after bariatric surgery. And that they will also understand the importance of follow-up, right? So patients who are really knowledgeable, right, are going to be patients that are not going to be just passive recipients of care, but they're going to be active participants in their care as well. So I think education is critical, and part of Bariatric Friday, Kemal, is to get that education.
It's also education for me too.
Improved, right? So no, it is very important. I think education really is very important in driving long-term success.
So one of the other factual things that what we know is patients who stay actively engaged with the coordinated bariatric care teams, at least 2 years after surgery, lose up to 25% more weight and average than those who do not. So these are good checkpoints for patients. Come to the bariatric surgeon for your annual follow-ups after the first year. Keep in touch with the nutritionist as you need, but make sure your primary care is seeing you not just for your annual physicals, but any follow-ups that you may have. So these are very important for our patients. So, so that's all we have for today, Dr. Ga.
Absolutely wonderful.
The care coordination is the backbone of a successful bariatric journey. It is what transforms a complex surgical process into a sustainable health transformation. So we have Dr. Erkan as our area of expert and giving us all the reliable clinical points and educating us. Thank you again. And we'll be back with Dr. Galvin next week for the support group aspect of bariatric surgery, and that's going to be next Friday, same time. So until then, please stay united. We'll see you soon.
Bye. Thank you.